All right, I'm Carlos, and my advisor is Mark Dretzy. I'm a fourth year PhD student, for those who don't know me. And today I'm going to present work on using open-ended stressor responses to predict depressive symptoms across demographics. This is work in collaboration with Philip Resnick, University of Maryland. It's one of the works that people mention came fruitful because of the pandemic and being able to work online. So one of the important reasons to study depression is because it's one of the most common mental health disorders, and as such, it also gets most of the research in the field. Here's, for example, a graph of the NLP data sets for each of these disorders. We see that depression by far has the most data sets. However, despite all the research being done on depression, we see that underrepresented minorities continue to be underdiagnosed and undertreated. And so the question is, why is that? Why does this happen? And there are multiple theories for this, but I want to point out two of them. So one is...
Let me talk you at the cost of maybe running over.
Yeah.
Go back to the previous slide.
Yeah.
So if they're underdiagnosed and undertreated, how do we know that?
So
how do you know something that doesn't happen?
At random samples, people have noticed that the rates of depression that we see across the US are different than those samples when diagnosed by physicians. Now, mental health is a very relative kind of diagnosis, like a physician may diagnose you and another one may not. So there's some grain of salt in those analysis, but it is of studies that have compared the general rates of depression as measured by the CDC and other studies that do cross-sectional studies across the US versus small scale, trying to be have a good diverse population in the study.
Okay, so is there a hypothesis then that there is no a priori reason why, let's say, Asian Americans should be less depressed than Americans overall, and then the data shows that of people diagnosed with depression divided by fraction of population of that demographic, that it's less for Asian Americans than overall, and that's how you reach this conclusion.
Right. So, well, I think what the studies are doing is comparing the rates of depression that we observe from overall versus that small sample, but we're not sure what those rates should be. Okay. Yeah, we just don't have any theory on saying that women should have more rates of depression than men. There's no theory they're just theories as of now. And obviously they are very dependent on how we define depression, how we diagnose, which changes constantly.
There's good reason to believe it's true, but the scientific method of saying roughly how much they have to diagnose one goes to.
Using the current way to diagnose for depression, it is reasonable to believe that this is true. However, is that definition correct? And going to that, some of the reasons that explain this differences may be I'm going to point into cultural relativity, which assumes that perhaps the differences in demographics or experiences in your life lead to different expressions in depression, and that perhaps our way of diagnosing depression is insensitive to these differences, and that perhaps that's why we see more rates of depression in some demographics than others. And the other one is that no, everyone actually expresses depression similarly, but we are just clinicians just have different thresholds for misdiagnosis, or the system does not allow clinicians to actually have access to subjects. So, but the key difference between these two is that either depression is the same among everyone, or depression has different expressions that may not allow us to actually observe or diagnose. All right. The other aspect of this is the relationship between stressors and depression, which is very complex. For example, stress is not only associated with depression, but with other mental health disorders, such as anxiety and PTSD. In addition to that, we also have seen a strong connection between stressors coming from major life events, and these are perhaps a family member passing away, or you're getting disease, a life-altering disease. So that's very well understood that it does contribute to episodes of major depressive disorder. On the other hand, however, we know that you can experience stress and not be depressed, and you can experience depression without experiencing stressors. And studies have ventured to pose that the relationship between stressors and depression is not causal, for example. So while there is some link between stressors and depression, it doesn't necessarily, we don't know how strong that link is, and we don't necessarily know the relationship between depression and stressors. However, I would say it is important to understand the nature of this relationship, because knowing about it could help physicians to better treat and diagnose people, for example, having stress management tactics during therapy. All right, so we know that there's some link between stressors and depression, and we know that different demographic groups have different rates of depression. For example, here I point out that women are twice as more likely to have depression according to the CDC statistics, and the rates among ethnicities vary depending on the study. You can find multiple studies that say that they're the same and multiple studies that say that they're different. So we really are not sure. But the question that I pose here is, can perhaps differences in stressors account or help us understand these differences in depression rates, for example, across demographics?
I'm going to parse the language a little bit, that women are 2x more likely. Are they 2x more likely to have depression in the diagnosed cases, or this is after factoring for some kind of underdiagnosis? This might be the true prevalent rate.
This specific one from the CDC is a instrument, just basically a questionnaire, where they have cutoffs for depression. So they just send this questionnaire to people to answer, and based on those cutoff scores, whether they have depressive symptoms or not.
Got it. So even if these people haven't come in for treatment, you can get an estimate saying, hey, if they answered it this way, they're likely.
Yeah.
Okay, perfect. Got it. Thank you.
All right, so we are using this unique data set, which it was collected by University of Maryland. That's where Philip Resnick comes from, comes into the picture. And our Data Helps group, where they administer surveys online. They were advertised on social media, and they had questions about demographics, also self-diagnosed, but more importantly, this mental health questionnaires that gives us an idea of the cutoff scores for symptoms of different mental health disorders. But also they have this open-ended question about stressors that ask them to describe the biggest source of stress and what have they done to deal with it. And this is important, and will come up later, that it is they're not only talking about stress, they're also talking about coping mechanisms, maybe. And this is where I come in, where I analyze the text. This is a view, the graph shows a view of the cutoff scores or the number of surveys that actually responded this open-ended text response. And you can see that all together, we have around 2,000 surveys. It's a very small data set. Looking at the number of surveys across gender and racial ethnic groups, we see that we have a slight overrepresentation of women and white participants. The gray bar is calculated based on the CDC depression rates and the US population, and the blue bars are what we observe in the data set.
This is from the questionnaire part.
Yeah, this is from filtering the questionnaire part of the data set that actually responded to the open-ended text responses.
Oh, they are coming from you.
Yeah. All right. And another thing to note about the data set is that it was collected throughout, so before and during the pandemic. So we have a very interesting view of the effect of the pandemic on the survey. So one thing to notice is that after the pandemic started, we have more surveys submitted with major and minor depressive symptoms. And so that led us to try to investigate what other differences were there after the pandemic started. And we noticed that beyond the depression rates actually being statistically different, so the more people submitted responses that showed depressive symptoms, also the demographic population was different. It was more diverse after the pandemic. And we checked back with the team and see if there were any changes on, for example, recruitment or ad differences. Maybe they changed something after the pandemic started, but they didn't change anything. So as far as we know, we can't necessarily explain this. It could be because the pandemic caused this effect, or it could be that it got within a certain group on minorities and they just shared the ad more.
Can you do some temporal analysis relative to George Floyd? I'm wondering whether that shift in the mindset of the people conducting the survey.
As in,
For them to realize that there are these disparities that they may not have been paying attention to. In other words, it might have had a positive effect on the way people go about their lives.
that is, they could have tried to answer the question more because of things going on, and that's true. And later on, I will point out that a lot of, so for example, the 2020 election was mentioned a lot.
Yeah.
And the Black Lives Matter protests were one of the biggest topics, along with the COVID pandemic.
It's that 6-month window.
Yes, it was a big year. So far we've seen that the national estimates for depression are different, and that perhaps there's a difference between before and after the pandemic in the data set, and that there is some link between stressors and depression, but we're not sure what that is. And so right now, we're going to see whether we can find differences in stressors across demographics. And once we find where there are differences or not, can we explore deeper into this relationship between stressors and depression and see if that relationship is similar across demographics. So the methods to compare the text of two groups to across demographics, we used the vocabulary distributions or the topic models. We went for very simple, interpretable ways of characterizing text. For the vocabulary, we used the logos ratio, informative, Dirichlet prior, with the vocabulary frequencies, or the linguistic inquiry and word count categories, which is a dictionary-based tool made by psychiatrists to categorize words. And the empath categories, which is very similar to the look categories, but rather than made by psychiatrists, it was made automatically via seed augmentation. So the benefits of the look categories is that it gives us a view from that has been tested many times in the psychiatry field, and the empath categories gives us a more broad view. So kind of think of it as like precision and recall. And a structural topic model, which allows us to add covariates to the topics and gives us a view into providing the effect of that covariates have onto topics. And what that allows us is, for example, seeing which topics are more related to which demographics. And in this graph, you can see that the topics more to the right are more related to surveys submitted by white individuals, and the ones on the left more related to by Black individuals.
What is the relationship?
So some topics were repeated. And it's interesting, for example, there were two topics, not only about relationships, but about talking about school. And they were specific to some demographics. We left it in there for completeness, but the way I read it is that relationships is just not, because they're the same topic, there are two topics that talk about the same topic, it is not the fact that relationships are more related to Black participants or the other.
But they are different topics in the sense the way the Black participants talked about relationships was different.
Was different, exactly.
So the labels have been put post-hoc, but the topic model created these.
Exactly. The annotators were instructed to just create a one-word summary of the topic, and they named the same word for those two topics. Yeah. This screen went black, but can
Just tap it,
okay.
it should come up.
Okay, cool. So now we found differences in stressors across the pandemic and across gender and racial ethnic groups, and I'm just going to go quickly through these. So we find for the pandemic very, I wouldn't say obvious things, but just topics that make sense. So for example, isolation and quarantining, we see that stressors related to interpersonal interactions were more likely before, and stressors related to household things were more likely during or after the pandemic started. And we see this across empath categories and also topic models. We see that health-related stressors were also more likely during the pandemic, clearly because of COVID across all the groups. And we see that financial stressors were also more likely during the pandemic, probably because of layoffs and all the financial hardships that happened because of COVID. So this gives us a sort of idea that our methods do work well because the results, at least for the COVID analysis, do make sense to us, and it's what we expected to see. Right now, going to differences in stressors across other categories. For example, in gender, we see that stressors related to health, family, work, and money were more related to women as well as friends. And for men, stressors related to language, religion, politics, and household, more related to men. However, something to point out is that not necessarily, for example, in religion, I don't think it was that people were stressed about religion, but because we asked about coping mechanisms, how to deal with that. Perhaps some of these keywords are actually related to how people are dealing with stressors, for example, religion or like pray. Something interesting that we see is that comparing these groups to their subgroups of after the pandemic started, we see maybe the loss of these coping mechanisms. So the stressors related to friends are lost for women, for example, and stressors and worse of stressors related to religion are also lost for men. So this maybe gives us an idea that it is not that perhaps that stressors changed that much, but that access to coping mechanisms did change, and that affected people more. And we see a similar sort of analysis for racial ethnic groups. We see that politics were mentioned a lot by people of color, which is what I was mentioning. They mentioned a lot the protest, immigration system. There was a very interesting, this is just by looking at the surveys, I noticed that when protests were mentioning on the white population surveys, sometimes they mentioned riots, and that was not the case on the other populations. So some sort of word differences that could be captured by this analysis. So in summary, we see that the data set is influenced by major life events, COVID-19 pandemic, the Black Lives Matter protest, and the 2020 elections, and they affected the stressors of people. And perhaps rather than changing stressors, one of the biggest changes of the pandemic was the absence of coping mechanisms. We see certain stressors that actually were pointed out by prior work, but we were able to corroborate the results using open-ended open-ended text responses, whereas before people had to check off stressors off a questionnaire. And now that we know that there are some difference in stressors, the question is the relationship between stressors and depression similar across demographics, or do these differences in stressors change that relationship? And the way we are measuring this relationship is by setting a classification task. So we take as input the open-ended text responses and predict for depression. More specifically, we binarize the task. We use cutoff scores for the kids' mental health survey instrument. We take greater than 7 to be depressive symptoms. This in the field is considered minor depressive symptoms. So essentially, we're combining the minor depressive and major depressive symptom categories for a binary label. And we trained language models on the text responses. Each text response has a corresponding different KID score or depression label. Dataset was split 90-10 train tests, and we used cross-validation for hyperparameter tuning just because it was so small. We use both linear models and neural models. So for linear models, we use multiple features that have been previously used effectively in mental health classifications, so TF-IDF, Bag-of-Words, Look, Empath, and macro average glove embeddings. Overall, through all the hyperparameters and all the variations of these features, I trained more than 1,000 model variations in those. And for the neural models, we used fine-tuned mass language models for the prediction to predict, and we fine-tune all of the layers, including the classification head, and we hyperparameter search over the learning rate and batch size. The models we chose to use in this experiment are mental BERT, clinical BERT, and normal BERT, and that's to give us an idea of the importance of the pre-training data. So mental BERT is, so let me start with BERT. BERT's our baseline. Clinical BERT is a BERT model that was further trained on clinical data, including papers about health care and also clinical notes. And mental BERT was further trained, so taking that trained clinical BERT more specifically to mental health datasets. So our idea is that perhaps mental BERT will be more effective at predicting in this task than clinical BERT, and clinical BERT more than BERT, and the neural models will be better than the linear models. And here I report the average and the standard deviation of the performance of the cross-validation of the models. And we see that, as we expect, the neural models do outperform linear models, however, not by much. We also see that the performance of the models is not great. The best model is 0.6. But it is to be expected because we noticed that the relationship between stressors and depression to begin with is not very strong. Something interesting is that while we do see an increase in performance of mental BERT, it's not as big as I expected, but it could just be that the signal is just not really there. Now we ask whether the performance is the same across demographics. And for this, we use a definition of fairness called the differential equalist odds. We care about equalist odds because it takes both into account true positive rates and false positive rates. We care about true positive rates because it is, in a sense, a resource allocation task where we want people to have equal access to care. And a way to do that is through diagnosis. And we also care about false positive rates because the healthcare system is a finite source. So if we tend to over predict for a certain demographic, they may use all of their resources. So taking this both into account, equalize us does that. And this specific definition is also intersectional. That means that it takes into account subgroups. For example, not only women, not only men, but African-American women, Hispanic men, and all of those. Looking at the results, and here, the higher is the worst, the lower is the better. We see that linear models tend to be more fair. However, if you remember looking at the results, the linear models were very close to random. So that just means that the model is random for all of the demographics. But there is some performance fairness trade-off that we observe regardless. If we were to look at the F1 scores by demographic, we see a very interesting point is that the biggest performance difference is not between the majority group and the minority group. This is actually between two minority groups. For example, in the BERT graph in the middle one, we see that the best performing group was Hispanic women and the lowest was Asian women. And neither of those are the majority label. The majority group, sorry, is white women. What is interesting about that is that maybe tells us that there are some differences in the signals. Because if it was about a data set size, we would see white women to be the best performing group. They're not. So in conclusion, we find that we find differences in stressors across gender and racial ethnic groups, that we can predict depression based on stressors, albeit, not the best performance, but this is expected due to the noisy relationship between stressors and depression. The models do not perform fairly across demographics, but the remaining questions is this to be expected? In that, is the performance difference because of this cultural relativity and that perhaps stressors do explain differences in depression rates, or is it that there just isn't enough a strong signal in stressors to really characterize stressors and this relationship between stressors and depression? Unfortunately, this data set is only 2,000 samples, but we are expecting to get a much bigger data set through a collaboration with a group here at Hopkins, perhaps next year. So it would be interesting to test this at a much bigger scale. Questions?
Back to the confusion slide, I'd like to add one third possibility at the bottom. Rather than wondering whether there isn't enough signal, maybe you could ask a different question. If a clinician read that same section, would they accurately predict whatever the rest of the questionnaire predicts and so on? And if they can, then it just means we need better models.
Exactly.
Not that there is a signal.
Exactly. So I've done this myself at a not thoroughly. I just looked at a couple of examples, and there is a lot of noise. There are a couple of times where people have been diagnosed with depression, but that week that they responded to the survey, their actual scores were much lower, and they actually didn't have depressive symptoms. But they mentioned, for example, I have been diagnosed with depression in the stress response. So to me, I would have classified that as the person having depression, but it just happened to be that week they didn't score high enough. And the opposite is true. I've seen the models really miss that someone really clearly had depression. But it is that's a good point, and I did want to get therapists to annotate the data set to see if they were able to do the task, but we just didn't have funding and time. Therapists are expensive.
So they are.
Yeah.
Were there other like unbalanced or priority things you did when you're calculating the loss to have the model, like maybe you penalize more for like getting certain demographics wrong?
No, and that is one of the tools to actually have better models is you have different, like you include this fairness definition in the loss function. I didn't do that. Right now it was just to measure, and I'm sure you probably could get fairer models if you include the definition in the loss or you train jointly with that.
Can you go back to that slide? That's one.
That?
No, you had the definition.
Oh yeah.
So you're saying
Yeah. Oh my god. There you go.
So you're saying that you train with this as your
they include that definition as part of the loss with a parameter and how important that is in loss, and you can hyperparameter over that parameter. There's also other ways to, so this is an in training example of how to do this. You could also grab this model and change your thresholds for each demographic based on this definition. That's called post-processing fairness. So there are multiple ways of doing this.
Is that getting it?
Sorry.
No, is that getting at some of the things you're asking about?
I missed the other part.
No. What I'm saying is this metric sort of penalizes having unequal loss.
Oh,
And
yeah.
so actually, I had a question for you. I've seen this a couple of times.
Yeah.
I've not given it a lot of thought.
Yeah.
Is there a nice digestible document about it? Has someone written a tutorial or a Wikipedia page?
I actually was considering of
The
not
right one then, because
I was considering of not doing this talk, but I was also just doing a fairness tutorial for the group.
okay.
But I decided to do this last second. I can point you
Yeah, just
to
send it to the whole group.
yeah, got it.
Because I haven't sat and stared at it long enough to really internalize it. I've seen it a few times.
And that you mentioned that perhaps it does affect the loss. It's one of the reasons why people think that there is a fairness performance trade-off, because you're adding something to the loss that doesn't allow for the most optimal. But through recent papers, as in like 2 months ago, I found that in practice, if you do were to hyperparameterize over that parameterization of allowing the model to have a different weight for this specific part of the loss, does end up with models that are as performing but more fair. Perhaps not as fair as they could be, but they're just more fair than without it, and keeping the performance.